Hi, good evening, everyone. I'm Dr. Prasad, consultant in emergency medicine at High-Tech City, Hyderabad, Yashoda Hospitals. So, I welcome you all to the Friday webinar series. Today, we bring you a very interesting topic, stroke, which is common disease burdening the both the patient and the healthcare system. So, to speak the more advances in the stroke management, I introduce you to Dr. Sharath Chandra, who has done MD from NIMS and has worked as a consultant in reputed hospitals. So he joined us, the Haddock City branch recently. So over to you, Sarath, on
Thank you so much, sir. Uh, Hi. So first of all, let me start off by wishing you a very happy New Year. And this is really, like sir said, it's a burning topic. And my goal today is not to tell you the management of stroke per se. We'll not go into those nuances. Let us just stick to recent advances and keep it short, simple, and know what's come up recently pertaining to our emergency department. Okay. So with that, let's start off. All right. So well, this has been there in foreign countries for a long while, but in India too, it made its appearance. There's something called pre-hospital unit. So we have to understand that the management of stroke, it's moving from the appearance in emergency department to the onset of symptoms right at their homes. The treatment is beginning from the homes itself. So the patient's entry into healthcare system is with an ambulance, right? When our EMS picks up the patient from from their homes, that's where your stroke management starts. So to bridge that gap and to reduce the time to do critical timely interventions like thrombolysis, thrombectomies, systems have been developed to bridge that gap and reduce that turnaround time, right? So this is something called a pre-hospital unit where things that could possibly be done in the ED can actually be done in the hospital during the transport itself. Let's say the transport time is 10 minutes. Why to waste that time just for transport when treatment also and some form of assessment can also happen? So there, things have developed like, we call them MSUs or mobile stroke units. Um, the Kovai Medical Center in Coimbatore, kudos to them. That's the first mobile stroke unit in India. It launched way back in 2017 and it had helped a lot of patients. So essentially, what does this contain? If you can see the insides of it, this is how it looks. Let me just get the pointer up. Yeah. So this is your CT console, and this is where your patient lies, right? And you have the radiology suite right here, the computer where you can see your scans right here, and then uh, you literally have a CT scan outside the hospital in the vehicle. So essentially, the emergency medical services or the pre-hospital paramedics are trained in such a way that they can diagnose stroke, at least detect stroke, if not diagnose. Okay, detect stroke and rule out a bleed. That's all we need, right, to do a thrombolysis in timely fashion. So this is the entire crux of developing this mobile stroke units where uh, time for CT scan can be reduced because CT can be done within 5 minutes, and then the images will just be uploaded right here onto the console. And whoever is there, if the paramedic can interpret, I don't think that will happen, which is why we have something called, let me see. Yeah. So this is how the inside of a stroke unit looks like. Let's think of this as a schematic inside a blueprint of a mobile stroke unit where you have a CT gantry, the console of the CT, and then you have the patient's bed. So the patient just lies here. If the CT scan happens, the patient just goes inside, the CT does it. And then you have something called telestroke monitor where you can have a doctor, either an ER physician or a neurologist on call with you so that that person can interpret the CT scan right there. He doesn't have to do a thrombolysis in the vehicle, but your CT scan is already ready, so you can probably be ready in your emergency department to get the thrombolysis done, right? Cannulas can be secured outside, bloods can be drawn, everything can be done outside. Why to waste that 10 to 15 minutes of time? when, minutes matter, right? I always remember this. Each minute, we lose like 2 million neurons, right? After stroke, which is why this turnaround time is extremely important. It's of paramount importance when we talk about this timely management of thrombolysis. So there have been two big trials, which these are called the Be Proud and Best MSU trial, and both have shown that there were favorable outcomes compared to direct emergency department review of the patient and then deciding on a CT scan and then thrombolysis. So the time to thrombolysis have been drastically reduced in patients who have brought in via mobile stroke units. But then again, uh, you really cannot expect to have these large stroke units in remote areas of India. Even in the foreign countries, even in developed countries, apparently they do not have mobile stroke units deep into the suburbs or even into the rural areas. It's mostly concentrated around the urban areas. So the urban population is who largely benefit from these mobile stroke units. And cost factors. The CT scan itself is expensive, right? Think about having a CT scan outside of the hospital to maintain them, to maintain the stroke units. It's going to take a lot, and the cost is translated to the patient's expense, right? So these are some limitations for this, but still, if we are heading towards this, is how stroke is advancing with the development of mobile stroke units, right? And so the EMS must, and as an ED physician or whoever is handling acute care strokes, should understand, should know how to um, assess the severity, not just screen for stroke. This is where you must pay a little attention. These tools are not to detect a stroke, but once stroke has been suspected, you use these to assess the severity. Why? Because all we are concerned about is something called large vessel occlusions, right? So we are moving beyond thrombolysis in strokes and we are heading towards thrombectomies. So thrombectomies are supposed to be done only when there is a large vessel occlusion, isn't it? So to detect the severity and to get an indirect evidence of a large vessel occlusion, there are many severity tools, and I have displayed all of them right here. What I personally suggest is I think you should just pick one and master it, right? So CPSS is a Cincinnati pre-hospital stroke severity scale, and then you have a RACE, which is like rapid arterial occlusion scale. PASS is pre-hospital acute stroke severity. FASTED, we all know, which is kind of a mnemonic for us to remember. It's facial palsy, arm weakness, speech disturbances, and then you have the time of onset, eye deviation, and denial and neglect, right? So each have their own sensitivity and specificity. I would like to bring your attention to this particular scale called VAN. It essentially stands for visual disturbance, aphasia, and neglect. All right. The problem here is that there is 100% sensitivity and 90% specificity. But there is a big caveat here. If you see here, the arm weakness is mentioned as sine qua non, which essentially means to apply this severity scale, you need to have an arm weakness. Without that, you shouldn't apply the scale. So, which is why when you already have an arm weakness, you are more likely to have a stroke, which is why then combined with arm weakness, when you have a disturbance or an aphasia or a neglect, you are more likely to detect a large vessel occlusion, which is why it's doing well in terms of sensitivity and specificity. But like I said, the caveat is if the patient doesn't have an arm weakness, posterior circulation strokes, maybe not that much of help. But otherwise, if the arm weakness is there, then you can apply this scale and you have 100% sensitivity, right? So these are some pre-hospital severity strokes, not to detect a stroke, but to assess the severity. Just understand that so many scales exist, but pick one and master it. That's what I would suggest. All right. So this is actually AHA approved overview of how to manage stroke right from pre-hospital thing. I know it's a lot. It's a lot on the screen, but I'll just simplify it for you. So first, you get a call. You dispatch your EMS, right? And after that, once the EMS arrives on screen, he obtains the initial vitals and provides ABC interventions, which is airway, breathing, and circulation. If these are not stable, there's no point in doing any stroke assessment because the patient may as well be dead, right? So ABCs do take priority over other interventions in stroke. All right, then you do a physical examination and you use a pre-hospital screening tool, which I have not mentioned here because there are not many updates in screening tools, but the FAST is one screening tool and you have Cincinnati pre-hospital screening tool. What we have seen earlier is a severity assessment tool, and you have a uh, pre-hospital screening tool as well. You have Los Angeles screening tool. You have so many screening tools just to assess if there is a stroke or not. And importance comes here when we have to obtain a point of care blood glucose first. And if the stroke is suspected through screening tool, then you initiate a stroke protocol right at the patient's pickup point. Could be home, could be office, whatever it is. All right, it's not the hospital. It's probably where the patient is being picked up. And we have to determine the last known well time. And after that, we have to perform a stroke severity tool, which we have discussed in the earlier slide to assess for potential large vessel occlusion. If there is no stroke suspected, and coming back here, then treat and transport as per patient's presentation. As simple as that, right? So when the stroke is suspected, and if you have a large vessel occlusion suspected, and if the last known well time is less than 24 hours, because that's what the window is now for thrombectomies, then you have to transfer the patient to EVT's endovascular therapy capable stroke center. Okay. And pretty hard to find these in India. So essentially, you can transfer the patient to various stroke centers. If you can notice here, ASRH is Acute Stroke Ready Hospital. PSC is Primary Stroke Center. TSC is Thrombectomy Stroke Center, and CSC is Comprehensive Stroke Care. So they kind of go up in their sophistication. So Acute Stroke Ready Hospital, they can just probably do a CT scan and do thrombolysis and then ship the patient. Right. Primary stroke centers, they can or cannot have thrombectomies with them, but then they do have some neurological capabilities. All right. And then you have thrombectomy stroke center where you have a dedicated neuro team to handle strokes. And of course, like the name says thrombectomy, the center has to be capable to do a thrombectomy. Then you have something called comprehensive stroke center where you essentially have everything, right? Including neuro-specific ICUs, not a generalized ICU where you have a, treat sepsis and all the stroke cases together too. No, that's not it. But comprehensive stroke center essentially has everything, including a separate neuro ICU, including a neurointerventionalist, including a neurosurgeon, a neurologist, and you name it, they should have it. All right. So the timing essentially matters as to where you want to ship the patient, right? So if the distance is large to a comprehensive stroke center, maybe you want to ship the patient to stroke ready health center so that the patient can get thrombolysis and then be shifted for thrombectomy. Okay, so this is just a beautiful outline. If you just go through it once, I think it's going to clear up your mind as to how a patient has to be directed, right? So this much time in pre-hospital has been mentioned because we have to move towards CMS in India. That is absolutely important because our care starts right at the home, not in the hospital. And pre-hospital care is uh, falls under our emergency department's purview. All right. And then, so there are two concepts here, which is called mothership versus drip and ship. Essentially, mothership is where you handle everything, right from doing a CT scan to performing the thrombolysis to doing the thrombectomies and manage the patient till the end. Drip and ship means you get the patient to a hospital where you can do thrombolysis, give alteplase, and then take the patient to a thrombectomy center. Because I hope you know that if the patient qualifies for both interventions, both thrombolysis and thrombectomy, both have to be done. Okay. It doesn't mean if the patient has come within half an hour and you have a thrombectomy ready, it doesn't mean you don't do thrombolysis. You have to do thrombolysis and then take the patient for thrombectomy. Right. So what do the studies say? So there were two major studies, RACE-CAT and triage stroke. So they mentioned there were not really big differences in outcomes when there was a direct transfer to a thrombectomy center, or you first do a TPA and then ship the patient, which is drip and ship, right? But in hemorrhagic strokes, direct transfer may have worse outcomes. Why? Because if when I say direct transfer, it means direct transfer to maybe a thrombectomy center or a stroke center. What happens is, suspecting, let's say you suspect a stroke and then you suspect a large vessel stroke, and then you ship the patient to a thrombectomy stroke center, and it took like 2 hours, and the patient actually had a bleed. Assume that. So what happens? The patient's BP probably shot up, the patient's edema probably went up. So the patient would have gone to an acute stroke ready health center. They would have done a CT scan and then they would have found a bleed. And then there you go, you have your diagnosis. You can do those specific interventions right there. Right. So in hemorrhagic strokes, it was shown that direct transfers may have slightly worse outcomes. So yeah, it all depends on patient specific criteria where you want to ship the patient and the uh, time of onset of stroke. Right. What do you think this is? We have a doctor, okay, and probably a paramedic who's delegating with the doctor over a monitor, right? So this is telemedicine. And apparently, so you have, especially in mobile stroke units, if you have a CT scan with you, you can talk with the neurologist, and it's as good as having a neurologist right there in your ambulance. And apparently, and happily, the reliability was as good as an in-person evaluation. Between a telemedicine evaluation of a neurologist to an in-person evaluation, there was a good reliability. So essentially, it reduced the door to CT times because the doctor would already know, okay, I'm dealing with this condition. So as soon as the patient is reeled into the emergency department, he would not wait for ED assessment again because the assessment would have been done in the ambulance itself or in the vehicle itself. So it essentially reduced door to CT times or door to imaging times. Thereby, it reduced door to needle times where you need thrombectomies and delivery of thrombolysis drugs as well. So telemedicine does work. If you have a telemedicine capability in your hospital, you can use it with confidence of an evidence-based backing, right? All right. So this sums up your pre-hospital assessment in totality. Now, well, just to mention a few newer tools because we are talking about advancements. Mobile EEG is one thing which is developed, not greatly used for strokes, but then it can be helpful in ruling out stroke mimics. Like if there is a seizure, like how mobile ECGs have been developed, mobile EEGs also have been developed. I don't know if we are doing it in India. In Hyderabad, it's not happening, but I don't know if your centers anywhere are doing mobile EEGs in the pre-hospital itself. Right. And then pre-hospital transcranial Doppler to find out large vessel occlusion. Very fancy thing. I don't see a lot of ED physicians doing transcranial Dopplers here. We'll talk about transcranial Dopplers in the coming slides. And then you have certain biomarkers like glial fibrillary acidic protein. You have troponins, you have NT-proBNP, and you also have heart-type fatty acid binding proteins. Why these? Because some kinds of MI also can fall in stroke mimics. And sometimes, if there is a slight elevation in troponins or NT-proBNPs or HFA-BP, it essentially means there is some, I mean, if not as much level as an MI, but there is a slight bump in the levels. It can probably indicate, something in the brain because strokes, bleeds also cause a bump in troponins and proBNPs because heart can kind of develop some stress and then release these enzymes. So these also have been evaluated, not robust evidence, but some evidence has been there. More trials are needed, right? So this is quite important actually. Pre-hospital reduction of BP. Apparently, there is no role. Interact is a series of large trials that check the blood pressure managements at various levels. So in pre-hospital stage, reduction in blood pressure did not prove to be beneficial either in the terms of outcomes or even in terms of mortality. So, right, that sums up our pre-hospital. Now let's come to our emergency department. Like I said, ABCs take the top priority. You have to do your primary survey and then go for other evaluations because if there is a problem with the primary survey, you probably are losing the patient, right? And this is a very interesting evidence here. So if you're intubating the patient of a stroke or if the GCS is less than 12, um, evidence has shown to consider giving ceftriaxone 2 grams as a single dose. Apparently, it is helping in preventing ventilator-associated pneumonias. So the Profivap trial, which came out earlier in 2024, showed that giving a single dose of ceftriaxone 2 grams if you're intubating a case of stroke, it helps in preventing VAP, right? And not much evidence for fluids apart from giving individualized treatments. Okay, so this is about ABCs. And now coming to the most burning topic and probably most confusing for people, blood pressure management. Multiple trials have been done. Now the evidence is easy. In ischemic stroke, remember that if you're giving, don't worry, I'll explain this out for you. If you're considering for thrombolysis, right, pre-tissue plasminogen activator, before giving that, your target should be less than 185 over 110. If you're unable to reach this with the help of drugs, do not thrombolyze, right? After you deliver your thrombolysis, the BP is going up, right? Uh, this will be your newer target. Actually, this is not a new evidence, to be honest. It's been there for as long as I remember. So after you give the drug, your target is reduced by 5. If you see here, it is 185 over 110, and now it is 180 over 105, right? Just to keep that safety margin so that the patient doesn't go into a icy bleed. All right. If you're not giving, or if the patient is not a candidate for thrombolysis, then your target should be less than 220 over 120. All right. This, I know that's a scary value, right? To have a blood pressure of 220 over 120. But evidence suggests that do not correct if the blood pressure is less than that, right? 210 over 110, you're still good. If it is an ischemic stroke, right? Now, if it is a hemorrhagic stroke, you have to maintain the BP less than 180. That's obvious, quite obvious. But benefits spawn up when the BP is maintained closer to 140. So the evidence which was there from before, it just got more solidified through the latest trial, where when you are maintaining blood pressure closer to 140, the Interact 3 is the latest trial where hemorrhagic stroke blood pressure management showed it, that if you're maintaining around 140 with other measures in the sense that, other measures of reducing the ICP, other routine care, and all those, it improved outcomes. Okay. So earliest trial was 2013 Interact trial, where target less than 140 showed a better trend towards showed a trend towards better outcomes. So which has been validated again in 2023 trial 10 years later, that closer to 140, good target for hemorrhagic strokes. So I'll repeat again, ischemic stroke, you have if you're not thrombolysing, remember 220 over 120 is your target upper limit, right? And these are so many trials that have been done. And if you can just take a screenshot of it and go through it later, so many strategies, right? And I want to emphasize this one, enchanted and optimal BP trial, right? After thrombectomy, maintaining too low values showed harm, right? So even after thrombectomy, this will be your target. Okay, even after thrombectomy and after thrombolysis, your target will still be 180 over 105 because the bleeding risk still exists, right? After doing an intervention, which is why your target is still 180 over 105. Not thrombolizing, then this is your target, 220 over 120. I hope this is clear. All right. All right, we are done with ABCs. Now let's go to DND. Sugars less than 180. If it is still 160, do not be scared. If it is less than 60, correct for hypoglycemia. If it is less than 180, you're good to go. But still maintain less than 180, more than 180, kind of not good outcomes. Okay, and head position, I see, people asking to elevate the bed in strokes to prevent aspiration and all. But what does evidence say? So there is something called head post trial. It is not really a new trial, but then I just wanted to mention here. Apparently, there's no difference between 0 and 30 degrees. But then again, it all depends on your patient factors, right? If the patient is too obese or if the patient has some lung infection, why would you want to keep at 0 degrees, right? Because there is no difference, when there's no harm in keeping to 30 degrees, I still prefer to elevate the bed a little bit. It's, as you all know, it's kind of a non-pharmacological method to reduce the ICP as well, because you use gravity to pull the blood from the brain through the veins. Okay. Though the evidence suggests that there is no difference, but considering other factors, you probably may want to incline towards 30 degrees. Fever, only treat if there is hypothermia. This is very important. thinking the patient may develop fever in the future or may develop infection. There is no role for prophylactic hypothermia. At the same time, no role in treating if the temperature is normal, and no role for induced hypothermia. Trials have been done. None of the trials showed a good outcome in induced hypothermia. All right. So our initial stabilization is done. Now, what's new in radiology? Unfortunately, I wish I could say so many new things have come, but same things have been validated over and over again. So let's see what's new in radiology. Okay, in neuroimaging. I know this is not something we kind of expect, especially if you're working in big corporates or sophisticated centers, you kind of tend to do MRA first. But still, considering stroke as a timely intervention, something of a critical importance when it comes to time, guidelines still say do CT over MRA. But again, they do not say that MRA is inferior. No, they always maintain that MRA is superior. But considering time as a factor, all you need to do is rule out a big bleed or a big tumor, right? So when CT can easily do that, why waste like 20 more minutes doing an MRA? But again, if there is an ease of access present, like you have an MRI suite immediately available, you have some protocol in place where you get a window period stroke and then the patient is reeled to the MRI and the MRI is done quickly, then MRI is found to be superior because it can pick up tiniest of the strokes, especially posterior circulation strokes, which is kind of missed up in CD scans, right? So SMART trial has proved that MRI could be better, but then again, the bottom line is only if there is ease of access. Otherwise, CT still wins. And nowadays, we are doing perfusion imaging right in the same setting, but then please understand it should not delay your thrombolysis time. Okay. Let's say the patient came at 4 hours, right? And you ship the patient to CT or MRI, and then you keep doing perfusion studies. You're losing that window to do thrombolysis within 4.5 hours, isn't it? So do not do that. What you do, you need to rule out a bleed, quickly rule out all contraindications, give the thrombolysis, and then you can take the patient again for perfusion imaging or angiographies or anything, right? So if it's not impeding with your timely delivery of thrombolysis, only then should you go ahead and do perfusion imaging in the same setting. All right. So aspect score, it's been there since forever, right? So you have a total score of 10. A score of 10 essentially means the patient is normal. So it is a small stroke, 6 to 7 is moderate, 0 to 5 is large. So for those who don't know what stroke is, this is Alberta Stroke Program Early CT score. So you have two levels. You check one at the basal ganglia level, all right, where you have your insular cortex, which is I, and M1, M2, M3 is the areas of distribution of your middle cerebral artery, MCA. And you also have, so this is the ganglion, basal ganglia level, right? So you have lenticular nucleus, internal capsule, and the caudate. So at this level and the insula. So these are all falling at the ganglion level. Once you go up, that will become the supraganglion level where you have M4, M5, and M6, right? As you can see in the images here. You have M4, M5, and M6 in the supraganglion level. So you have M1, M2, M3, M4, M5, M6, 6, and then you have insular cortex and 3 in the basal ganglia. Caudate, lenticular nucleus, and internal capsule. So each gets a score of 1. You have 10 areas that you see. And if there is a gray white matter differentiation and something, signs of stroke, which is, trust me, aspect score is quite hard to pick up on CT scans unless you are extremely trained in it and you have a radiology backup. It's kind of difficult to pick up, right? But then again, each damaged area gets a score of 0. So if the score is 0, that means it is very large. If the score is 10, it means it's normal. Okay. If it is normal, you get a score of 1. If it is abnormal, you get a score of 0 for each area. So 0 essentially means all 10 areas are gone. That means it is a very large stroke. Okay. So 0 to 5 is large, 6 to 7 is moderate, 8 to 10 is small. Now, I think as ED physicians, we need to kind of understand what angiographies and perfusion imagings are as well. So which is why I'm taking 5 minutes of time to give a brief outline of what perfusion imagings are. So you have something called multi-phase CT angiography. Okay. So where you have three kinds of lesions, right? Red is a lesioned area and blue is a normal structure here. Okay, you can see the red circle here, right? So what's happening in phase one? The normal side has picked up this contrast, right? And in phase two, there has been a washout in the normal side, but there is a delayed pickup in the affected side or the disease side. In phase three, washout is complete. Still, washout is just about to begin. So this is the kind of graph that you get. So there is just a delay. Okay. So this happens when there is a small ischemia, not a bad one, where there is a tiny block which is causing a delayed uptake of contrast. So that is one kind of lesion. And you have a greater extent of lesion where, if you can see in phase, type B, in the pickup is there. The pickup is lesser on the affected side. Okay. The washout is happening. There is a delayed washout. This is how the graph happens in that. Okay. So the pickup is less and the washout is delayed. So here the lesion is more severe. And you have a third lesion where there is a complete block, right? So the normal side picks up the contrast well, whereas the affected side does not pick up, does not wash out as well. Okay. And if you look at the graph, this is how it's going to appear, isn't it? This is the normal pickup, and then no pickup, and it is, if at all it is there, it is very much reduced. So this essentially gives you the severity of occlusion of your vessel, right? So this is how multi-phase CTA is imaged. And then you have something called CT perfusion study, right? Looking at this, it's going to be scary, right? But it's quite easy to understand if you know. So essentially, it's based on the maximum contrast if it's appearing before the venous uptake occurs. It essentially means after the arterial phase happens, venous pickup happens, right? So is the arterial phase happening in the same way much before the venous phase, which is actually normal. If it's not happening, it is going to time the arterial pickup of the contrast with the venous phase. So if the arteries are appearing red, these arteries that you can see in the image, that means they contrast pickup is early, quite early, which is normal. If the arteries are appearing green, that means their pickup is similar to when the veins are picking up. I'm going to repeat again. If the arteries are appearing green, that means their pickup of contrast is similar to when the veins are picking up. That means there is a delayed uptake, isn't it? If the arteries are appearing blue, that means the pickup has happened after the veins have picked up the contrast. So there is a much, much, much longer delay, which means the occlusion is more severe. So if you can see in the arrow mark here, as it's mentioned, until the origin of MCA, you can see red color pickup by the arteries. That means until then it was normal. Then going here, you can see green happening. That means the contrast is being picked up when the veins are picking up the contrast too. And then distal MCA area, where probably the infarct is the maximum, you have blue. That means the contrast is getting picked up after the veins have picked up the contrast. So that means you have a large vessel occlusion here and this entire area is underperfused. Okay, so this is how CT perfusion studies exist, and trust me, this is not a radiologist or a neurologist job. Stroke management is moving more towards outside the hospital. So these radiological aspects will tend to move towards the ED now, which is why you have to know them. All right. And then you have MR perfusion imaging. It is kind of similar to diffusion flare mismatch. So what happens is you clearly know that, see, this is how a normal diffusion flare, diffusion images exist. This is a stroke, right? This is a stroke. Then you do a perfusion imaging. So you kind of get the stroke in red, and then this entire area of penumbra is still amenable to treatment. Okay, so there is hypoperfusion, but there is no diffusion restriction, which means this area is still getting perfused. It just did not undergo infarction yet. Yes. So which is why, so this much area of penumbra is there for you to save. And if this much area is the penumbra, that means a huge artery is blocked, isn't it? Which is probably, probably your MC is gone. Okay. And it is amenable to treatment. So if you do something, give a thrombolytic or do thrombectomy. So this entire thing opens up, isn't it? This entire thing opens up. So you're essentially treating the penumbra. That's the entire crux of stroke management, isn't it? So MR perfusion imaging is quite easier than CT perfusion imaging. If you have this, try reading scans 1 or 2 times, and then it's going to be easier later on. All right, now focus is, it is replacing the stethoscope. Little bit fortunate, little bit unfortunate, but transcranial Doppler, don't think it's a neurologist or a radiologist job. Trust me, ED physicians are doing transcranial Dopplers these days, and it's actually not that difficult. All you have to do is place the cardiac probe right at the temporal bone, right in the middle of the temporal bone, right? So that's actually, there are multiple views to do transcranial Doppler, but in the emergency to look at stroke management, I think transtemporal view is ideal view. So this is how the imaging goes, and this is how, yeah. So this is how your image normally looks like, okay? So your probe is kind of here, right? Your probe is kind of there. So when that is being translated to the image this way, this is how you're going to see. You can see red here, that means flow is towards the probe, okay? Because M1 comes like this, isn't it? And blue is away from the probe. So see, can you see the circle of Willis happening here? It's quite easy, right? You can see the nice circle of Willis happening here. And if there is M1 or M2 occlusion, at least large vessel occlusion, you can quite easily pick up by just putting the color flow onto the image that you obtain. Okay, so the same thing is translated to an ultrasound image this way. Okay, and this is the schematic diagram, right? So for you to understand better, this is the schematic diagram where this is how it's going to appear, isn't it? So transcranial Doppler, okay, now you may ask me, now, okay, we got the images and we did the image acquisition. Now what? So there is something called flow velocity, right? So if you can see this MFW here, it essentially means mean flow velocity. Don't worry, if you just hit the pulse wave Doppler, PWD, right? The PWD spectral Doppler, if you hit it on the MCA, it's going to give you this flow diagram, right? Velocity curves it's going to give you. So there is something called peak systolic velocity and end diastolic velocity. So between that, you get mean flow velocity. So you can see here, don't worry, the ultrasound machine does the job for you. All you need to do is hit the probe, hit the spectral Doppler at the right area. That's it. And you can see here, the mean flow velocity is given as 69 centimeters. So anything less than 80 apparently is reduction in blood flow, and less than 30 is critical stenosis. So just remember these values, okay? All you need to do is calculate mean flow velocity. The machine will do the job for you. All you need to know is how to acquire this image and how to hit the right pulse wave Doppler at the MCA level. Okay. All right. Now let's come to the next management. Now we are done with the initial ABC assessment, neuroimaging. Next comes is your fibrinolysis or thrombolysis. Right. Well, if I'm talking about recent advances in here, you have window extension. Let's talk about how the guidelines are talking if the patient presents more than 4.5 hours, right? So currently, till this date, guidelines still maintain the window of 4.5 hours. Okay, we are yet to see an improvement in the guidelines or an upgradation, but still the guidelines, both the European and the American guidelines maintain 4.5 hours window. All right. So many trials have been done. My favorite trial actually is the wake up trial, right? It was kind of stopped in between, but it did show improved outcomes in unknown onset, wake up stroke. How long does a patient sleep for? 8 hours, maybe? Okay. If he's waking up with a stroke, you do know that he was fine until 8 hours back. So if there is a diffusion flare mismatch, right? If there is a diffusion flare mismatch, that means the penumbra is still amenable for an intervention, for thrombolysis, essentially, isn't it? So it showed improved outcomes, but then it did not uh, propel itself into the guidelines. But then later on, so many extended trials have been done. One was extend trial in 2019. Again, MR perfusion mismatch was the criteria in imaging, up to 9 hours or wake up. Like I said, 8 hours is the maximum or 9 hours for wake up. Yeah, that's how long you sleep. And altiplase increased favorable outcomes. So even in late windows, if you have diffusion flare mismatch, I think you can, at least case to case basis, you think you need to go ahead and thrombolysis. That's my opinion. Though the guidelines still maintain the window of 4.5 hours, you can still do that. Okay. Because all these trials have been showing improved outcomes, right? And then again, the latest one was Rose TNK trial in 2023. They took it to the next level and did if there was a mismatch even in 24 hours, they did with tenecteplase, and though there was no clear benefit, there was no harm either. So maybe few patients do benefit and more research has to be done, right? But if there is a diffusion flare mismatch, maybe if the patient is just within that, just more than 4.5 hours, let's say 5 to 6 hours, I think you need to consider for thrombolysis, considering the significant benefit thrombolysis offers. All right. Now, coming to newer agents for thrombolysis, well, the OGs or the original gangster is still altiplase, recommended by guidelines. Tenecteplase has obtained FDA approval. So, in the upcoming guidelines, expect tenecteplase to be in the guidelines as well. And I personally think it's much easier to deliver just at a dose of 0.25 because altiplase goes for an hour, right? But tenecteplase, it's a single bolus dose. You give it and then you're done. All right. And it has certain advantages, like it is more fibrin specific. And then you have newer drugs like desmoteplase, which goes at a dose of 90 micrograms per kg. Apparently, it has high fibrin specificity. I don't think it's available in India yet. And then you have staphylokinase, purokinase, and importantly, retiplase. Let's talk about these last two drugs. So in 2023, there was a trial called PROS trial where purokinase and altiplase were um, put up against each other and non-inferiority was met. So the trial itself was a non-inferiority trial, thinking purokinase, if it is not inferior to altiplase in giving your outcomes, okay? So the risk difference was 0.89 and minus 6.5 to 8.29. That means there was no difference. That means purokinase is non-inferior. Now the cost and all, I'm really not sure. Has to be looked up. We still don't have it in India, right? Retiplase. In 2024, RISE trial assessed retiplase versus altiplase because retiplase is available in India, and I thought I should put this up because retiplase apparently was found to be potentially superior with a confidence interval of, I mean, it's not including one. So the benefit was slightly more with retiplase, but on the flip side, you have more symptomatic intracranial hemorrhages happening with retiplase, but the outcomes were slightly better. So retiplase, the dose is 18 milligrams, which is 10 units. Okay, if it is translated to units, it is 10 units. Okay, and followed by another 10 units 30 minutes later. Same as how you do in MI. Okay, so if you really do not have altiplase or tenecteplase, and if you're getting retiplase at a cheaper rate, probably it's something to consider because it is backed up by a good randomized control trial. Though it is yet to make its place into evidence, still it is a first stepping stone, if you ask me, right? All right. So many trials have been there comparing initially streptokinase and then you have desmoteplase. So many trials have been done. I want to bring your attention to the RISE trial, which I have already mentioned, has been done in China. Okay. And nowadays, tenecteplase, altiplase, so many trials, safety is equal and outcomes are equal. Tenecteplase, initially it was started in this NORTH test trial at a higher dose, but then it did not, hemorrhages were high. So then the dose was reduced to 0.25, first time in Extend IATNK trial. And then they did again a dose with 0.25 versus 0.4 mg per kg. In that trial, ICH was more with 0.4 mg per kg. So evidence supports a 0.25 mg per kg dose of tenecteplase. It is evidence-backed. FDA has given its approval, so tenecteplase can be safely used in patients with stroke. All right. Now, coming to your exclusions for thrombolysis. So AHA and EAC guidelines have, the European guidelines have given a lot of exclusions, right? So I'm going to put up those exclusions which are paving way for new evidence. Are they still considered exclusions? Let's look at them. Okay. Earlier, within 48 hours, direct oral anticoagulants like dabigatran, rivaroxaban, apixaban. Okay. So within 48 hours, if the usage was there, it was a class 2 recommendation. So they were asking not to thrombolize the patient. But now, meta-analysis in 2020 and a retrospective cohort in 2023 both suggested that there was no significant bleeding risk. So even if the patient has taken oral anticoagulant within 48 hours, if you think the patient is in window period, you can go ahead and do thrombolysis with a little more vigilance, of course, right? And this is most important, right? This is a practice-changing guideline here. Earlier, within 3 months, if there was an ischemic stroke, it was an absolute contraindication to do thrombolysis. But now we have noticed that there is a greater functional benefit even if the patient has an ischemic stroke within 3 months. But if that previous 3 months was within just 14 days, there was a significant increase in intracranial bleeds. So what does this mean? If the patient has stroke within 3 months, but not within 2 weeks or 14 days, you can safely thrombolize still. Then again, I would say you need to consider other factors as well. But if the other factors are okay, and if this ischemic stroke is the only holding back factor, I think you can consider giving thrombolysis. But then again, if within 14 days, a big no. Okay. And then benign neoplasms of the brain. If the patient has a benign neoplasm, you can go ahead, and in 2022 a systematic review suggested that there was no increase in ICH. So these are some practice-changing updates, right? Which is why I wanted to put in traditional exclusions. I think it will pave way to newer guidelines. So many newer guidelines have come up, and they're officially yet to release the guidelines, both AHA and European guidelines, right? And then the final thing is thrombectomy, right? Mechanical thrombectomy. All right. So many trials, so many trials. I'm not going to bore you with these statistics and all, but trust me, the important things are you have this attention trial, best attention and bioacute trial. Essentially, they talk about posterior circulation strokes where effective, where mechanical thrombectomy was effective, yes, in posterior circulation strokes as well, right? So that's very important. Just a second. Okay. All right. So in mechanical thrombectomy, posterior circulation strokes, earlier when the guidelines came out, posterior circulation stroke was a big no. But then uh, these two trials, essentially the attention trial and the bioacute trial, they clearly showed benefit in posterior basilar artery occlusion as well. So even posterior circulation stroke within 24 hours, still a candidate for thrombectomies. So these were the original OG trials, Dawn and Diffuse trial, and then they paved the way for thrombectomy trials have been done way back in 2015. But extending the time window was done by these trials, Dawn and Diffuse. And after that, it cascaded into so many other trials, Rescue Japan Limit trial. In 2022 and 23, that was again a golden period for window extension for thrombectomy. So many trials have been done, and so many trials have proven benefit even in large core. Earlier, the criteria for doing thrombectomy was aspects if it is more than 6. If the aspect score was on more than or equal to 6. But then again, 3 to 5. Large score in facts. Everything showed better outcomes. MRS is modified Rankin scale. That's how you check the functional outcome in stroke, right? So every window extension has shown that there is a better outcome with extending the window up to 24 hours. Okay. All right. So with this, let's talk about medium vessel occlusion. Okay. Many trials are they're going beyond ICA M1. M1 is the first branch of middle cerebral artery, right? So they have gone beyond M1, and they did try doing thrombectomies in M2 and M3 as well. But studies consistently showed no benefit or more harm, right? Latest one was Dusk trial. It was done, it was a retrospective cohort, but then no benefit when thrombectomy is done in M2 or the second branch of MCA. Trials are ongoing. Discount trial, Digital trial. So, well, I need to correct it here. Escape Mevo trial, it was published already. I mean, in late 2025. I'm thinking November, right? Escape Mevo trial, but then the outcome was still no difference, right? So still no difference. This Escape Mevo trial has been published, but no difference and no use in doing thrombectomies to medium vessel occlusion. So the evidence still stands ground. No benefit of doing thrombectomies to medium vessel and small vessel occlusions. All right. So certain other advances, because sometimes few EDs receive the patients after 1 or 2 days. So patients, sometimes even EDs deal with a part of critical care as well. So which is why I put them here. Tracheostomy, set point 1 and 2 trials, they did not show any difference. If the tracheostomy was done between 5 or 10 days, it did not show any difference in terms of mortality, right? And then fluoxetine, earlier when Flame trial came out way back in, I don't exactly remember the year, but it was at least 4 to 5 years back. It showed kind of minimal benefit. But then again, subsequent trials, so many trials have been done, focus trial, affinity trial, FX trial, no benefit of fluoxetine in acute stroke. And then we tend to give neuroprotectives like, neranitidine and then nootropic. So many drugs have come, but no consistent benefits in functional outcomes. Okay. So your priorities still remain the same. Identify the stroke, screen for stroke severity, transfer the patient as soon as possible to appropriate stroke center, assess if the patient is a candidate for thrombolysis, go ahead and do thrombolysis. If it is less than 24 hours, you are good to go for thrombectomy as well. Of course, there are some criteria, and then if the patient meets, he's good to go for thrombectomy, right? Now, I cannot finish my talk when I'm talking about recent advances without talking about AI, okay? Don't worry, I'm not gonna give you codes or anything here. It's just that artificial intelligence was found to be pretty useful when it took the job of assessing the pre-hospital severity if you just input the symptoms, right? So pre-hospital severity prediction and direction also, where to ship the patient. So and the trials were done with the use of LLMs, which is LLMs are essentially all the models that you use today, like ChatGPT, Grok, Perplexity, DeepSeek, everything, right? And they have been found to be useful for large vessel occlusion prediction and neuroradiology also. Okay, it kind of pains me to say that they are slowly going to replace the need for acute radiologists for ED interventions, and stroke is one of the areas where AI will probably help us in not troubling our radiologists. Okay, and then AI enhanced imaging. You tend to get some not every center may have 128 slice CT scans or advanced MRIs, right? But still, with AI, the purpose of AI is it feeds on data. The more images you do, the better it gets at predicting, right? So if you have AI enhanced imaging, it kind of predicts your lower quality images as well. And those have been shown in studies also. Okay. And outcome prediction, both therapeutic in the sense that after thrombectomies and functional, which is modified Rankin scale, outcome prediction, it is correlating pretty well with a doctor doing the outcome prediction. Okay. So AI tools are coming up. If your center supports AI research, these are some areas where you can probably do some research on or at least work on AI, right? And then stroke risk prediction. This is, of course, not a acute stroke management, but then based on the risk factors, AI apparently is giving an individualized prediction percentage to patients saying, okay, this is the risk of stroke for you. I mean, this is the percentage of risk that you may develop a stroke. So it is doing well even in stroke prediction, considering all the data given to it, right? So this is where AI is finding its way in stroke management. Of course, it's finding its way. It has found its way in every walk of our lives, right? So it's just a matter of time before it takes over. But then at least you should understand that these are the areas where AI is coming up, and probably if you're interested in it, just make yourself aware of these. Okay. So with this, these are my references for all the stuff I put up here. And if you have any doubts, I'm open to receiving them. Thank you so much for your patient listening. And this is where we conclude. Thank you.
Thank you, Dr. Sharath. It was a very candid and lucid talk, and it was very informative. So I think I'll just check the questions in chat box. Okay, chat box is empty.
Okay.
So, okay, thank you again once again for the session. We'll
Thank you so
conclude.
much, sir. Yeah.
Thank you so much.